Thank you for joining us today for our webinar, When Nature Cross-Reacts, a closer look at pollen food allergy syndrome, diagnosis, management, and treatment. I am Jennifer Gertz, Executive Director of Food Allergy Canada, and today our expert joining us is Dr. Ann Ellis. Before we get started, I'd like to note a few housekeeping items. Note that this session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you very much to everyone who submitted questions upon registration. There are some common questions that we will tackle in today's session. If you have additional questions during the session, please submit them in the question box throughout the webinar, and we'll try to get to as many of those questions as we can. And lastly, this webinar will be recorded and shared on foodallergycanada.ca afterwards. So a little bit of background of the session. Pollen food allergy syndrome, PFAS, sometimes called oral allergy syndrome, is one of the more common allergic conditions, yet it's often under-recognized and misunderstood. Rooted in the cross-reactivity between proteins and pollens on certain fruits, vegetables, and nuts, pollen food allergy syndrome can leave impacted individuals with confusing symptoms that overlap with food and environmental allergies. Today's session is designed for both individuals living with pollen food allergy syndrome and those, including healthcare professionals who support them. Together, we'll explore the science behind cross-reactivity, practical approaches to diagnosis, and strategies for effective management. Our aim is to make pollen food allergy syndrome easier to understand and to help you navigate living confidently with this condition. To help us do that, we are joined by Dr. Ann Ellis. Dr. Ellis is a professor of medicine and the chair of the Division of Allergy and Immunology at Queen's University and holds the James H. Day Chair in Allergic Diseases and Allergy Research. She is a director of the Environmental Exposures Unit and the Allergy Research Unit at Kingston General Hospital, the past president of the Canadian Society of Allergy and Clinical Immunology, and also serves on the Joint Task Force for Practice Parameters, which represents the American Academy of Allergy, Asthma, and Immunology, as well as the American College of Allergy, Asthma, and Immunology. We are delighted, Dr. Ellis, to have you join us in your very busy schedule, so I'll turn it over to you for your presentation.
Thank you very much, Jennifer. And I can say with certainty that you are probably the most expert introducer of me because you didn't struggle with anything to do with American Academy or the American College when it comes to allergy, asthma, and immunology. And it's usually there's a lot of that. It sort of falls apart half the time when people introduce me when they get to that part of my bio. So thank you for the kind introduction. And it's a pleasure to be here with this audience to talk about something I see quite frequently, and I would say increasingly so. So very timely and very happy to be able to help people who are experiencing symptoms of what is now known as pollen food allergy syndrome, what used to be called oral allergy syndrome when I got started, but we understand more about this condition now, and hence the new name. So when I say PFAS, this is not to be confused with PFAS, which are pesticides, which of course then just makes things a little bit more complicated. So we are talking about pollen food allergy syndrome here today. These are my disclosures. As Jennifer alluded to, I run the Environmental Exposure Unit and the Allergy Research Unit, which involves a lot of clinical trials for new therapies for allergic diseases, including allergic rhinitis, asthma, and urticaria. So I wind up with a lot of affiliations with industry, but I have not received any industry support today whatsoever in my discussions. I will talk briefly about antihistamines and epinephrine autoinjectors. So some relevant disclosures is I have done things in the past for Medexus and Searchlight Pharma and Pfizer, which is the distributor, used to be the distributor of EpiPen. It's now Viatris, but I don't think I've actually done anything for Viatris. So regardless, this is free of any industry influence whatsoever in this presentation today. So learning objectives, I'm hoping after you hear today's talk, you'll be able to understand the basics of pollen food allergy syndrome, recognize reactions when they occur, engage their severity, and talk about the different management strategies and treatment options that we have for this condition. So First and foremost, we'll make sure that we review specifically what is food allergy, what is the basis of food allergy as it relates to pollen food allergy syndrome, what are the various symptoms that patients experience, how do you diagnose this, and what becomes important here is the concept of food families to help you recognize where do environmental allergies and food allergies overlap and coincide, and who are the common cross reactors. And obviously, we'll talk about management strategies and treatment for this condition. So, food allergy, it's important to recognize that bad things can happen when you eat food generally. I have the same sort of approach to drug allergy, really, because you can have adverse reactions or abnormal reactions to food that aren't necessarily an allergy. So, you can have toxic reactions, so bacterial endotoxins or food poisoning, for example, salmonella. So if you've got contaminated chicken, you could have a bad reaction to an ingestion of a chicken meal, but that's got nothing to do with allergy whatsoever. It's because there's food poisoning involved. And then you have non-toxic reactions to foods. So we have issues that are food allergy, which means the immune system is involved and is causing problems due to its own misbehaving, or an intolerance, which is another type of reason that you might want to ingest that food, but it's nothing to do with your immune system. And I'll give you some examples of both of these as we go along. So food allergy, of course, high focus for this audience. This is what we mean when we talk about IgE-mediated food allergy, a sort of classic food allergy, right? So this is when you get symptoms like anaphylaxis from the ingestion of a food of which you're allergic to. So again, symptoms of hives, itching of the mouth, swelling of the lips and tongue, shortness of breath, could be all the way to a systemic reaction, or it can be IgE mediated and milder. So this so-called oral allergy syndrome that we're talking about today, or pollen food syndrome. Patients with food allergy can also have a mixed process that's both IgE mediated and non-IgE mediated. And so an example of that would be something like eosinophilic esophagitis, where patients can have issues with certain foods and dysphagia or difficulty swallowing, but not necessarily symptoms like that make you think that they're at risk for anaphylaxis. And finally, non-IgE mediated food allergies. So classic example of this is food protein-induced enterocolitis, or FPIES, which occurs in young children and results in profound diarrhea and bloody diarrhea, usually with certain foods. Unfortunately, FPIES tends to be outgrown. And it's harder to diagnose because it's non-IgE mediated. So our usual skin testing that we do when you come to an allergist's office doesn't always help us. And we really have to rely on the history in that circumstance. Food intolerances are more common than food allergies. Classic examples here would be lactose intolerance, which is due to an enzyme deficiency where patients don't have lactase, and so therefore they get diarrhea and other abdominal discomforts when they consume milk products. Also, you can have just sensitivity to foods. So some patients might think they're allergic to caffeine or aspartame, for example, but really it's just pharmacologic sensitivity to or chemical components of a food. So example would be caffeine or aspartame, as I've said. And then we also have psychologic food intolerance. So you just don't like the taste of it. It makes you gag because of whatever reason, the smell puts you off. That's more food aversion. So again, that's another example of a food intolerance type reaction. So when do we suspect food allergy? Again, for IgE-mediated food allergic reactions, that this is something that happens immediately. So we used to call this, type 1 class, Gell-Coombs class sensitivity. So it's immediate hypersensitivity to foods. It's IgE-mediated. This means that within 15 minutes, usually no less than 2 hours after the exposure to something you're allergic to, you will develop symptoms of urticaria, for example, or hives, respiratory symptoms. Manifestations may be cardiovascular or gastrointestinal. So we really base it on within, an hour at most, usually, of ingesting the food. You get classic recurrent symptoms. Again, what some of the clues to this type of allergy is what is the food that people are reacting to. There are so-called top 10 major food allergens that are known to be foods that are much more likely to be involved with allergic reactions than others. In theory, one can be allergic to anything that's non-human, but there are the usual suspects like milk, egg, wheat, peanut, tree nuts, fish, shellfish, sesame, soy, mustard, rounds out that list. And those are the things that make us think that this is most likely to be a food allergy. And again, this is where you could have potentially anaphylactic reactions, and why it's important to get diagnosed properly and determine your actual risk properly where possible. And usually the suspected food is not something you eat regularly. So it's very unusual to be allergic to something you eat on a regular basis. Food allergy is not hidden. If you have stomach upset or just don't feel well after every meal, that's not a food allergy. That's more likely to be an intolerance. Again, if you continue to eat something you're actually allergic to, that will progress to anaphylaxis at some point, and it won't be hidden or a surprise to you anymore. As I alluded to with FPIEs or other non-IgE-mediated food allergies, this is when you get severe and often delayed gastrointestinal symptoms. So it's within 2 to 4 hours of eating a meal, as opposed to immediately after eating something that you could have these non-IgE-mediated food allergies, such as FPIEs. So just to show you a pictorial representation of what sort of happens in your immune system when you get exposed to something you're allergic to, we talked about the fact that it's mediated by this antibody called IgE. IgE likes to live on the surfaces of mast cells, which are our allergy cells. When IgE comes into contact with the allergen that it recognizes, it leads to cross-linking of these IgE molecules, which tells the mast cell to degranulate and release all of its mediators. So this is where you get histamine, but other important vasoactive mediators as well, which lead to vasodilation and effects on smooth muscle, both in the airway epithelium, the blood vessels, and your smooth muscles, that all lead to symptoms that can manifest in your skin, again, with hives or another rash, in the lung with shortness of breath and chest tightness, in the intestine with diarrhea, nausea, vomiting, and other symptoms, usually all of which, if they happen together, suggest a systemic allergic reaction or anaphylaxis. So what about this so-called pollen food allergy syndrome? What is it and how is it different than just regular food allergy? So again, like food allergy, it all starts with sensitization. But in this case, what happens first is you become sensitized to an environmental pollen. So rather than being allergic to the food first, you start off being allergic to something like a birch tree pollen or grass pollen or ragweed pollen. And usually what happens is you get symptoms first of hay fever or allergic rhinitis for the medical terminology. So that leads to symptoms of runny nose, sneezing, itchy, watery eyes, nasal congestion that happen consistently at certain times of the year. So in the spring for birch tree, for example, or if you live in Ontario and Quebec, you can get symptoms in late August and early September for ragweed. And once this happens, you now may notice that you've suddenly developed itching of the mouth and throat after you eat certain fresh fruits and vegetables and rarely certain tree nuts. And this actually can occur in up to 75% of patients who have become allergic to birch tree pollen. So again, people who have had hay fever for many years will be trucking along, and it's annoying, and they're quite miserable with their hay fever. But regardless, they mostly don't bother presenting to anybody because they can use over-the-counter antihistamines or what have you. But now they start to get itching of the mouth and throat when they eat an apple, for example, or other fresh fruits and vegetables, and become concerned that maybe they have a food allergy, and maybe they need to carry an EpiPen and lots of different things. So it is important to determine whether or not this is a true food allergy or whether you just have this cross reaction with birch tree, for example. So why exactly does this happen? So there are proteins that are shared between some fruits and vegetables that are very similar to those found in the pollens. These are plant defense proteins, so things that have evolved to protect the plant from things like insects and other things that can be damaging to the plant are also defense proteins for these fruits and vegetables. It's the same sort of idea. It's like there are certain defense proteins that are there to protect plants in general forms, and also some nuts. And because it's this shared defense protein, those IgE antibodies that I showed you earlier can cross-react with these these proteins that are found in both sources of both in the pollen and in the certain foods. And this leads to pollen food allergy syndrome, or you may have heard of it before as oral allergy syndrome. And the reason why we used to call it oral allergy syndrome is because typically the symptoms are limited to the mouth, so itching mouth of throat. But we now realize that the entire gastrointestinal system can be impacted, which is why we now expanded it to pollen food allergy syndrome. So even if you get upset stomach, nausea, vomiting, diarrhea from the ingestion of raw fruits and vegetables, it's still part of the oral allergy syndrome, or PFAS, and not truly anaphylaxis or quote unquote true food allergy. So again, as I alluded to, the typical symptoms include that itching of the mouth, the tongue, the roof of the mouth, and the throat. Occasionally, you can get additionally the lip and tongue swelling, as well as nausea, vomiting, and abdominal pain and diarrhea, particularly if you consume a large amount of the cross-reactive food. But what's an important historical differentiator is the symptoms are not present if you eat the food when it's cooked or processed. So a classic history is I eat a fresh apple, I get itching of the mouth. I eat applesauce or apple pie, and I'm totally fine. So again, similarly, fresh peach, but I have a peach smoothie from fill in the blank restaurant and it's fine. So again, cooking the food in question usually flattens those proteins, and those cross-reacting epitopes can't bind anymore, and the symptoms go away. So again, the proteins, and the reason why this happens is because these proteins that are cross-reactive are heat labile, which means once you cook them, you flatten the protein, and those IgE antibodies can't bind anymore. So you don't get that cross-linking we talked about. You don't get mast cell degranulation, and therefore you don't get symptoms. So it's very common that patients can eat cooked carrots, for example, but not raw carrots, which is a little bit more common than people cooking their fruit, for example. Now, this can happen from time to time as well when it comes to peanuts and tree nuts, which can certainly, as you can imagine, cause a little bit more anxiety than just itching of the mouth when I eat an apple. Because tree nuts and peanut can cause these types of symptoms as well in birch sensitized patients. So it's birch allergy only that cross reacts with the tree nut family and peanuts on occasion. So the other environmental allergies like ragweed and grass, fortunately, don't have this potential. But nevertheless, birch allergy is common enough, and this cross-reactivity with tree nut is certainly seen, and hazelnut in particular is quite common. We also see it with peanut and cashew. Symptoms that patients experience typically remain in that mild category, and if you can be confident that this cross-reaction is pollen food allergy syndrome as opposed to a true-bill hazelnut or peanut allergy, you can be reassured that you're not at risk for anaphylaxis, and you don't actually need to carry an epinephrine auto-injector as a result of having itching of the mouth when you eat hazelnut, for example. So it is very helpful to be seen by a specialist who can help determine whether or not the itching of the mouth you got when you ate peanut or a tree nut of some sort was actually due to your birch allergy, as opposed to an actual problem that could put you at risk for a more impressive reaction if you were to eat peanuts or tree nuts. So these food families, just to try to help put them into categories, these are not perfect by any means, and it's it's an evolving area where we learn a little bit more almost every year about what things can be cross-reactive. But common culprits in people who are allergic to birch, so tree allergy, is from the fruits. You see apples, apricots, from vegetables, carrots, and celery. Really, any pitted fruit is a good thing to think about. So cherries. We also see kiwi, peaches, pears, and plums, and occasionally soybean. But this is the one where, importantly, you can see issues with almonds, hazelnut, and peanuts. And I'll talk to you shortly about how you determine the tree nut story here. The other pollens, so grasses, tends to cross-react with oranges, peaches, potatoes, watermelons, and tomatoes. Ragweed is a very common culprit in Ontario and Quebec, so I see a lot of patients who have itching of the mouth and throat with things like avocado, banana, cucumber, mango, melons, all the melons, so not just watermelon, but cantaloupe and honeydew, for example. It's also been described with apricot, paprika, potato, and zucchini. And then mugwort, interestingly, which is another weed, also pollinates in the same time of year as ragweed, but it's a very different plant. cross-reacts with some of those cruciferous vegetables like broccoli, cauliflower, cabbage, Swiss chard, but also some spices like garlic, onion, and parsley. And this is where bell pepper can become a culprit too. So increasingly, I'm skin testing people now routinely to mugwort as part of my environmental panel, because it helps to explain some of these other oral allergy syndrome fruits and vegetables that I didn't have a good explanation for before. And one of the things that's important and can help you when you're trying to figure this out, if you're somebody who cares for patients with food allergy and allergic rhinitis, is that symptoms of pollen of food syndrome can occur any time of year, really. But a lot of patients will notice that their symptoms are worse if they eat the culprit food during the relevant season. So if you eat something that, let's say, for example, an apple in birch tree season, your symptoms may be worse than they would be in the dead of winter. And I do have patients who say they can eat stuff through the winter fine, but once they get into their hay fever symptom season, that's when they realize, oh, that's too uncomfortable and I'm not going to bother. So this is still an evolving sort of map of when the seasons are. Again, climate change is making everything a little bit different. But for the most part, if you're in Ontario and Quebec, or I don't know where our full audience is, but you can appreciate that tree pollen season usually gets started basically once it's finally warm in the air, which is around April for the most part, unless you're lucky and live in British Columbia, where you can get tree pollen season as early as February. May and June, though, pretty consistently is our grass pollen season. And for those of us who are lucky enough to have ragweed, with mainly the eastern parts of the country, the Atlantic provinces across to Manitoba, late August through to the first frost is when we see ragweed. So far, the prairies and BC do not have ragweed, but ragweed is an invasive species, so stay tuned. Eventually, it will catch up with you out there as well. And one of the things that you may find helpful, I really liked this picture. I actually printed this and laminated it from my clinic. On the Food Allergy Canada website is a nice, helpful reference guide for not only what are these things that you could be allergic to cause hay fever symptoms, but also what are the cross-reactive fruits, vegetables, and nuts where appropriate. And it also gives you a bit of a clue as to the seasons when you're most likely to encounter these allergens as well. So how do we diagnose this condition? So again, history is really key here. And in fact, 99 times out of 100, I could probably make this diagnosis just on the history alone, because you've got symptoms of allergic rhinitis or hay fever. You have them at the right time of year and in the right season to correspond with tree, grass, or ragweed allergy. This is not something that occurs with perennial allergen sensitization. So those people who have year-round symptoms only, this is not something that you see with dust mite allergy, for example. And then you've got symptoms that go along with oral allergy syndrome. So again, it's itching of the mouth and throat, maybe nausea, vomiting, maybe diarrhea, maybe some lip swelling, but you don't break out in hives. You don't have respiratory symptoms or loss of consciousness, nothing to suggest a more impressive systemic anaphylactic history. So you sort of pair those two together. So you've got hay fever seasons and symptoms in the spring, itching of the mouth and throat when you eat apples or carrots, for example. Then we move on to do confirmatory skin testing to environmental allergens, as well as to foods of concern if we have the extracts, or sometimes to the fresh food or vegetable, as the case may be, if we don't have an extract in clinic or it's just not commercially available. And that can be helpful. So you've got this, let's say, for example, a positive skin test to birch and a negative skin test to an apple extract, but a positive skin test to a fresh piece of apple. That kind of cinches the diagnosis right there. Occasionally, we need to move on to fancier blood tests. So maybe measuring serum-specific IgE to the food of concern, or more importantly, specific components. So we've actually evolved in our laboratory diagnoses now, where we can measure not only the IgE antibody to hazelnut, for example, like we used to have when I was training, but now we can actually look for what are the specific parts of hazelnut people are allergic to. So we can confirm through these expanded lab tests whether or not you're allergic to that defense protein only, as opposed to other proteins within hazelnut. to help distinguish, is this actually a hazelnut allergy or is this a birch allergy with a little bit of cross-reactivity to hazelnut? So we do have these components of allergens we can check IgE levels to, which to help distinguish true nut allergy from these birch-related cross reactions. So, for example, that we have a specific one called, it just happens to be called ARA-H8, which is the epitope of relevance for peanut that cross-reacts with birch, CORA-A1 for hazelnut. And occasionally it can be more difficult to sort out, or you're just not quite sure, or you really want to have a definitive answer one way or another, then we might go on to an oral food challenge to cinch the diagnosis one way or the other. Obviously, those expanded testings like serum-specific IgE and component resolved diagnostics or component testing and oral food challenges are only going to be offered by certain subspecialist clinics, and that'll be variable depending on where you live, access to the same. And the coverage for those blood tests may or may not be covered by the provincial health plan. So, for example, those component tests are not covered by the Ministry of Health in Ontario. So patients do have to pay out of pocket for those specific tests if they're ordered outside of a hospital setting. So you may see that could explain why some people get a different workup than others, depending on where they live in the country. So this is somebody from my practice I thought would be a nice case example of a 22-year-old female who'd had symptoms of hay fever for many years. Her symptoms were worst in the spring, but she put up with her symptoms. They seemed to be okay to just deal with over-the-counter antihistamines and Flonase. But she had had a recent episode of severe mouth itching and lip tingling after she'd eaten a big serving of trail mix. And so she was sent to me for evaluation of possible tree nut allergy. I did, obviously, after I got this full history, I went on to do skin testing, and she was indeed skin test positive to birch and ragweed. I did skin test her to the full tree nut panel because of the concern, and it was trail mix. So, you don't know exactly which nut might be the issue, and you do want to know about, there's always a chance of cross-contamination, even if that had just been pure peanuts in it, for example. And fortunately, her tree nut skin testing panel was negative to everything except hazelnut. Relatively small test, but still enough to be considered positive. So I did go on to do specific IgE testing in this case. I didn't need to do specific IgE to birch because we've already confirmed that with the skin test. But you can see her hazelnut IgE in total was, and these numbers are somewhat arbitrary, but 1.08. And then her different components, I was able to do the full panel. Her CORA-A antigens 8, 9, and 14 were all undetectable. Those are the ones that are involved in true hazelnut allergy. But CORA-A1, which is the one that cross-reacts with birch, was right up there at 1.02. So accounting for pretty much all of her hazelnut positivity is all due to this defense protein shared by hazelnut and birch pollen. So she was happily reassured that she's only going to get itching of the mouth if she eats hazelnut by accident. She doesn't need to worry about having more systemic reactions. She doesn't need to carry an EpiPen, for example. So people sometimes ask me, what do these numbers mean? What does this part mean? And it is kind of hard to explain. And nobody's come up with really nice. I looked for quite some time for somebody who's made a really good cartoon to better explain this. But hopefully you kind of get the assessment here. This are X-ray crystallography assessments of protein structures. So birch pollen, the major allergen, is known as BET-V1. And you can see all these epitopes that are very similar in appearance and basically similar in structure from all these cross-reacting foods like you see in cherry, celery, and peanut. I think you can appreciate, if I'm an IgE antibody, those things sure look a lot like to me, and I'm going to bind to them one way or another because they look too similar for me to distinguish between the two. And that sort of drives a lot of the so-called cross-reactivity that we see. In terms of her history, as I've alluded to, this is one of the cases where the atopic march is somewhat flipped on its head. So those of you who've been paying attention to allergy over the years probably recognize an image like this where everything starts in infancy with atopic dermatitis and a broken down skin barrier, and that allows sensitization to foods, and food allergy onsets usually early in childhood. But in this case, it happens the opposite way. So because you become primarily sensitized to the environmental allergens, You get symptoms of allergic rhinitis as opposed to food allergy first. And then later you get those symptoms of food allergy, but it's really because of the cross reactivity with those things that drove your allergic rhinitis in the first place. So it's almost like a flipped atopic march in setting of food, pollen food allergy syndrome. So, how do we treat this? Well, it's easy enough to avoid the food that causes your symptoms. But as I alluded to, if you cook the food or heat treat it in some other way, that changes the protein composition, and it can flatten the protein and can lead to no cross reactivity. And many times that's all you need to do. Just eat cooked carrots instead of raw carrots. Use canned fruits or vegetables instead of fresh fruits or vegetables. Now, do they taste as good? Probably not, but it means that you can still keep that food in your diet. Sometimes peeling the fruit or vegetable is enough because often that plant defense protein is in the skin. Makes sense. It's there to defend the outer surface of the fleshy part of the fruit. So sometimes that's all you need to do. Sometimes patients will choose to continue to eat the foods, but they'll pre-treat with a second generation non-sedating antihistamine. I'll jump on my antihistamine soapbox in a second. I also have patients who pursue allergen immunotherapy. It's treating two things. It treats their allergic rhinitis, and it also can make their pollen food allergy syndrome symptoms go away. And I have several patients in my practice who now can happily eat mangoes, who were highly sensitized to ragweed before. And similarly, I see improvements in pollen food syndrome from patients who have birch allergy. And we just have a discussion about the fact that you do tend to have to target a little bit higher doses in your allergy shots, which just might mean you're going to have to put up with a little bit more allergical reactions. But we know it works, and depending on how much your pollen food allergy syndrome symptoms are affecting your quality of life, a lot of patients will pursue this as a way to solve two birds with one stone. There's a lot of press about the role of omalizumab for the management of food allergy in general because of its approval for the treatment of food allergy in the US. That is potentially something that would work for this as well. It would be off-label, and it is not an inexpensive way to go, but it should work. So in theory, yes, it's an absolute possible treatment. Most patients choose to pursue one of the things I've said above as being easier and less expensive, but it is out there as an option. Very, very rarely do I have patients where I'm concerned that their symptoms are severe enough that maybe we should move on to an epinephrine auto-injector, or maybe they've got a mixed picture where I think 99% of their symptoms are just due to this pollen food syndrome, but I can't 100% exclude the possibility that there's a little bit of involvement of some of those other epitopes, if you will. And I will prescribe an epinephrine auto-injector, but it's the majority of patients do not need it. It's about 1% at most who could be at risk of systemic reactions and therefore actually need an EpiPen, which I can say because right now that's the only one we have in Canada. So again, if you're going to use antihistamines either before or after eating a culprit food, just a reminder to use a second generation antihistamine. Please do not use Benadryl. The side effects of Benadryl far outweigh the benefits. It was interesting. I had a pediatrics resident in my clinic yesterday who said, I didn't realize that it's also not a good antihistamine. I just knew how bad it was from a safety profile. So we do have much more effective antihistamines that are exceptionally safer. So all the second generation antihistamines are better to use, and we have lots of them in our armamentarium. Some of them are covered by drug plans to help you save the out-of-pocket cost. Lots of them are available over the counter at your local pharmacy. And all of them except for Allegra are indicated in the pediatric population at various ages. So lots of things to have as an option in your tool belt. So again, you can treat PFAS with either taking a second generation antihistamine either daily because it's helping your allergic rhinitis symptoms too, or at least 1 hour prior to consuming your culprit food. And as I've indicated, you can actually treat PFAS with immunotherapy to the aeroallergens. Some of you may be familiar with the new sublingual immunotherapy tablets. They should work in theory as well, but all of our data for true benefit so far comes from injectable immunotherapy if you're wanting to look for an evidence base to back it up. So in summary, Pollen food allergy syndrome can easily be concerning for or confused with so-called true food allergy. But again, it doesn't carry the same risk of anaphylaxis. So it's a very different prognosis. Can be easily managed by only eating the culprit food in a heat-treated state, or as I alluded to, pre-treatment with a non-sedating antihistamine. In terms of other treatment options, immunotherapy can be beneficial and does require a specialist assessment, obviously, to get going on that route. And specialist assessment can certainly help determine if you're truly allergic to the food itself or if this is PFAS, can help with your risk determination and these advanced management strategies. And epinephrine autoinjectors, again, usually not necessary for this condition. And with that, I'm going to conclude, and I will happily take any questions. I'll leave this slide up for an extra 10 seconds so that people can write down my contact information if you have any other follow-up questions for me. But after that, I'm going to stop sharing and happy to chat. Thank you.
Thank you so much. That was a great presentation. And we've got a number of questions that have come in and some that were pre-submitted. So let's start tackling the first group. The first group of questions relate to kind of that cross-reactivity and being able to the underlying concept around PFAS. So just remind us again, that underlying mechanism, why pollen allergy can cross-react with foods. Just let's restate that for the audience.
Yeah. So if you think about plants, they all are made up of different proteins, and IgE antibodies are things that help to drive allergic reactions. They need to bind to something that they recognize. So they bind to proteins. And there are proteins that are shared between birch pollen, for example, and birch trees and other fruits and vegetables. So these plant proteins look very similar, or they are actually the same protein in some cases. So antibodies that were developed to try to manage a reaction to a birch pollen that you inhale can then also bind to, or so-called cross-react with, these proteins that are found in, let's say, for example, carrot, or in certain circumstances, certain tree nuts like hazelnut, for example. So
okay. And so then you also mentioned that heat, when you cook it, in many cases, that changes the protein structure so people can consume it. Does that include things like fermentation, freezing, roasting? Like, is it all like what is kind of, help us understand, what's the mechanism to change or make that protein digestible and not
yeah,
reactive?
in the circumstance of fruits and vegetables, it's very straightforward. So any kind of cooking or processing and occasionally freezing, it doesn't seem to work quite as well, but it does sometimes, clearly really changes things. And you can appreciate that. A cooked apple looks and tastes very different from a fresh apple. So you can almost conceptualize why that would happen. But again, I try to show those pictures of what proteins look like in their complex states. And you can appreciate if you heat them and they go flat, they're not going to look the same at all. So those IgE antibodies can't bind anymore. They've lost those little bits, those hooks, if you will, that they latch onto. Roasting is a bit different because it doesn't seem to make a difference to nuts for the most part. In fact, if anything, roasting is, we think, one of the reasons why we see more nut allergy in general. But definitely in the circumstances with fruits and vegetables, cooking flattens them and it goes away. It's really hard to interfere with the tree nut cross-reactivity in any way, shape, or form. But and there's not a lot of data for fermenting, but for the most part, heating or otherwise processing or doing anything to it to make it like I say, if something's a store-bought version in a package in the middle of the grocery store as opposed to on the edges, chances are good that you changed it enough that it won't do that cross reaction anymore.
Yeah. And is it similar for spices and seeds in terms of their ability to cooking to actually change the protein and make it less reactive?
Yeah, you can see that certainly with garlic, because that's the most obvious one that people tend to use fresh garlic as opposed to garlic powder. You can definitely see differences in that circumstance too.
Okay. So now the next question is around, these food families. So if I've got a birch pollen allergy and I'm reacting to raw apples, not the cooked, but raw, will I react to all those other fruits and vegetables that you had listed there?
Great question. So the short answer is not necessarily, and usually not. So usually when you look at that laundry list of potential cross reactors for birch, most people don't tick all the boxes. There are the few exceptional unlucky individuals that I've come across where, yep, every single one of them, yep, 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 yep. But most people, it's one or two at the most that they notice. And I would say the average is 4 or 5. And usually there's one that's worse than all the others. So you don't have to preemptively avoid foods on that list, really
Right.
based on what actually gives you symptoms. Because the best way to become sensitized is to continue to avoid something on a, the more you eat something that
Right.
you tolerate, the better chances are you'll continue to tolerate it.
And so, and I suspect that along the same lines, the way to figure this out is to try the foods. It's not
Yeah,
like going into your allergist and say, please help me introduce all these foods into my diet that I might be worried about, right? That are
exactly.
related to pollen food allergy syndrome. And if you
Yeah.
have been consuming them, then that shows you're not reacting.
Exactly. So again, the gold standard for the diagnosis of food allergy is what happens when you eat it. So if you've been eating
Right.
it all along and it doesn't bother you, don't worry about avoiding it in the future. Continue to eat anything that doesn't bother you. And yeah, again, the with this being something a condition where you're not at risk for anaphylaxis, you don't need to get a panel of tests from an allergist to tell you what you can and can't eat. It really can be based on what gives you an itchy mouth and what doesn't.
Okay. So on the signs and symptoms piece with, with PFAS, typical itchy mouth. Now you're also seeing potentially some gastrointestinal, maybe some lip swelling, but nothing in terms of a respiratory basis.
Correct. Yeah.
Can you just have the gastrointestinal, or is the real kind of standard on this? No, it's really about oral itch is going to be there all the time.
Almost, I mean, you can never say always and never say never in medicine, but
Right. Yeah.
almost always you get mouth itching and then add in gastrointestinal after that.
Okay.
It'd be
Okay.
very unusual to purely be gastrointestinal. Um, you can't say never, but it'd be unusual.
And what about, we had someone ask about eustachian tubes. Can you get any reaction in the eustachian tubes?
Yeah, you can get itching of the eustachian tubes as well, particularly if you also have itching of the palate. It just sort of transcends, if you will. All on its own, without any other symptoms at all would be unusual,
Yeah.
but not entirely outside the realm of possibility, but usually something else would be itchy too.
Okay. So it's not pollen season. Okay. And is it possible outside of pollen season where someone doesn't have kind of any hay fever symptoms to eat the raw food?
It can happen. Yep. It just depends on the degree of sort of your threshold, and how much your immune system is revved up and already, I've been reacting to birch pollen for the last week. And so I'm ready to find some more to defend off this horrible foreign invader kind of thing. So yeah, I do have patients who can tolerate it just fine in the winter. And then I have other patients who it doesn't matter which time of year it is, they still have to avoid it.
Okay. Now we've had someone talk about, what, I can eat some fruit in Colombia, but I can't eat it in Canada. We also had someone say, what, when I'm traveling in Europe, I actually I don't experience pollen food allergy syndrome. What's the help us understand that?
So yeah, it's sort of speculative, to be honest, but I think it's probably a combination of one, what are we doing to grow our fruits and vegetables in North America compared to other countries? Um, if you can recognize that these are defense proteins, so maybe our fruits have to be hardier to survive the growing season in Canada. So you can appreciate that maybe we do grow apples with a little bit more, profilin or protein defense proteins in their skins than they would say in Europe. It could also just be simply, you're more like you're still around your Canadian allergens in Canada, and therefore your immune system is more on the alert. Could there be other things in our fruits as well? Like, again, as I sort of alluded to at the beginning, pesticides do sometimes complicate the story because other things can make your mouth itchy if you haven't washed off the residue of pesticides. So that comes up a lot. But I think the important thing is that people have realized that there can be differences in terms of seasons and locations so that you don't completely deprive yourself of these fruits that you enjoy.
Okay. Now, this is not an uncommon situation in our audience where people have members of their family that have both a food allergy, like an IgE-mediated food allergy, and also have pollen food allergy syndrome. So, and the big worry is always, is that pollen food allergy syndrome actually, is that what it is? Is the reaction that I'm seeing that, or could this turn into anaphylaxis? So walk us through kind of how you distinguish those between those two, and so that we've got better confidence in our audience in defining which path they might be on.
Yeah, so it's a combination of what are the foods involved. So again, when you're looking at fresh fruits and vegetables, statistically, much more likely to be in the pollen food allergy syndrome camp. Um, and again, this is where if it is something we get itching of the mouth with a tree nut or a peanut, where it's probably worth the trip to see an allergist to get that to help you sort that out. Um, and also recognizing that, you know, when in doubt, it's probably best to assume that it's more severe than PFAS when you're looking at something like a peanut type reaction situation. Um, but having said that, again, if it is things that, you notice that there's differences if you cook the food, or if it is more of a fresh fruit or vegetable that's causing the symptoms, you're much more likely to be in the camp of PFAS as opposed to true risk of anaphylaxis, just because your mouth got itchy. Yeah.
Right. So just if we've got people in the audience who've got peanut or tree nut reactions that are happening, taking that step to go to your allergist to get
Yeah.
a real clarity around, am I dealing with pollen food allergy syndrome, or am I dealing with the primary peanut or tree nut IgE mediated reaction? And your example, by the way, I thought was very useful around how the tests can delineate that. And is it common then for do you ever see PFAS develop in childhood? Because you talked about the atopic marge, and your example was a 22-year-old. But if someone has got a child who has a peanut and tree nut allergy and an early diagnosis, is that ever likely to be PFAS?
It would be in the older children, possibly. Again, we don't usually see environmental sensitization until a child has lived through at least 3 or 4 pollen seasons. So typically, we don't see positive skin tests to aeroallergens, particularly seasonal aeroallergens, until at least age 4, 5, or 6. So again, if you're having issues with peanut and tree nuts and you're 2, odds are much more in favor of this is a true nut allergy. Whereas if you didn't have an issue with hazelnut or peanut, for example, until you were 8 or 10, and you have hay fever symptoms, then you could well be in the PFAS camp, and it'd be worth finding out for sure. I mean, hopefully anybody who's worried about peanut or tree nut as a food allergen is seeing an allergist anyway. But regardless, it is possible, but it'd be older children as opposed to the younger ones.
Right. Okay. And if someone along this idea of having other kind of comorbidities, if you have PFAS and asthma, would you have a different approach to management, or what's your perspective on that?
Yeah. So in terms of risk, which is also, I think, what you're kind of getting at with that question is, are you at higher risk from PFAS because you also have asthma? The way we worry about asthma and asthma control in those patients with true food allergy, it's not quite the same kettle of fish. In that I'm not anymore worried about a PFAS patient just because they have asthma. However, I'm much more likely to wind up recommending immunotherapy as opposed to antihistamines, because now I know I can benefit not only their PFAS but also their allergic asthma by dampening down their immune response to seasonal aeroallergens. So I'm improving not only rhinitis and asthma, but potentially PFAS too. So that's the main differentiators. Now I've got a third reason to get on
Okay.
board with management. Yeah.
Right. Okay. Now, another couple of questions. Then we'll move on to some questions around managing the condition. So, with oral itching to certain spices, can spices they're not on that usual typical list of PFAS other than garlic, but could that still be a PFAS related reaction?
I mean, we're learning more year after year. So again, parsley wasn't on that list until a couple of years ago. I think we may encounter that. Again, I think it does come back to the more people are using like closer to the roots, right? So if you're using turmeric root as opposed to dried turmeric powder, the more processed anything is, that seems to be a better degree of separation in terms of minimizing reactivity when it's
Okay.
PFAS. So I think we'll learn more as we go along. Yeah.
Okay. And then last thing on walnut. Does walnut have like are these four categories of cross reactions of plant cross reactions generally the only four categories, or is there something that walnut would actually cross react with a different type of plant?
That's a great question. We certainly know that there's different epitopes we can now parse out for walnut and cashew on our testing. For the most part, we've done most of our research around BETV1 in the birch pollen
Okay.
family, but certainly as we start to care more about other trees, I think we're going
Yes.
to learn
Okay.
more. But I sort of,
Okay.
it might be easier to just lump it as it's tree allergy can cause issues with tree nuts in certain circumstances. Yeah.
Okay. Okay. Let's talk about management. So, you know what? I like this food, right? I've got PFAS, but I'm going to eat it because it really isn't, it's a minor oral allergy, itch. I don't, I can tolerate that. Is that okay?
Yeah. Yeah. This is not something that goes on to get worse and worse and worse and progress to anaphylaxis. So
Okay.
if you
What if I
don't
eat a
mind,
lot of it? What if I
well,
eat a lot of it? Should
so
I know you told, say, take the antihistamine in
yeah.
advance, but if I eat a lot of it, like, is that, what's your
So
recommendation? Would my system become more reactive over time?
yeah, so I don't know that would necessarily become more reactive over time, but I have seen literally, and I think you brought this up because I shared it with you in some of our pre-work, this guy who ate literally 2 bags of hazelnuts in one setting and had a pretty impressive reaction that I thought was systemic. And turns out all he's allergic to is that one cross-reactive epitope for hazelnut. That it's all tree nut, it's all tree allergy, it's all birch, but he ate too much. So, in theory, if you go crazy, and let's say an entire, bushel of some of a fruit,
Right.
I think in theory, yes, you could drive yourself
Right.
to a much more impressive reaction if you overwhelmed your system. But
Yeah.
again, if you're going to take an antihistamine and eat an apple, chances are you'll be fine.
Right. Okay. Now, we had a question from a dietitian that we thought was a really interesting one. She's actually running a cooking and food prep activity. And so when you think about people that are in those situations and they have a participant who has pollen food allergy syndrome, what precautions would you recommend that they might need to take in those situations?
Yeah. So again, fortunately, the risk is going to they'll become uncomfortable. Like they'll get itching of their mouth if they accidentally were to get some of the food they're prepping into their mouth. Um, but I would, generally recommend the same sort of things you would do in any circumstance. You could wear gloves. You could just make sure that you don't eat the foods that you personally react to. Um, and just sort of taking typical precautions about handling anything you're allergic to, but just know that the consequences of forgetting are going to be much milder than in the sort of setting of a true bill food allergy.
Okay, terrific. On the question of gloves, we did have a question come in around latex fruit allergy. Okay, we didn't talk about that today. Is latex another example of cross reactivity with fruits?
Exactly, and it's the same sort of concept in that people who have become sensitized to latex, it's the same sort of thing, and it's you even recognize some of the fruits from the list I already gave. So it's avocado, banana, um, uh, are the a kiwi are the three big cross reactors with latex, but that's exactly what it is. It's a cross reaction, and it's the same sort of concept.
Okay, and then does the same concept around cooking those things also change the reactivity?
Often it can, but not as consistently
Okay,
with as it is with birch cross-reactivity. Something about that latex plant, Hevia brasiliensis, it's a resilient plant by default because that's how you can make
right,
such impressive products from it. Um,
right.
but I usually exercise more caution in avoiding cross-reactive fruits with people who've true bill latex allergy.
Okay, we have a few more questions. And are you all right, Dr. Ellis, if we go over for a couple of
Yep.
minutes?
Yeah.
Okay, perfect. So we had some questions come in around honey. Okay, given that there's pollens in honey, like if you have pollen food allergy syndrome, will honey be a problem food or could it be helpful? Like, is it kind of an immunotherapy opportunity because you're consuming the pollens? So help us untangle that one.
Yeah. So certainly it's only local honey that's non-pasteurized are the ones that still may have little residual bits of pollen in it. The risk is exceptionally low. I'm not too worried about it. If you do have issues with consuming local honey, you might get some oral allergy type syndrome if there is a lot of pollen in it. And so therefore you just switch to pasteurized honey, Burt's Bees or whatever it is, like something that's a brand name that's in the grocery stores. They won't have any pollen in it anymore and it won't be an issue. Is it a therapy? No. I wish it were. It comes across all the time. I tell everybody it's delicious and enjoy it, but it's not going to help your allergies.
Okay. Now, on the piece around treatment of reactions with antihistamines, this pre-treatment of or preventing those reactions, can continual use of antihistamines ultimately reduce their effectiveness over time?
Great question. Fortunately, not. That is one thing it's nice to have a common therapy in my my subspecialty that is not only safe and well tolerated, but does not diminish efficacy over time. Patients will often tell me, well, I took Reactin all the time and it seemed to work and then it stopped working. So I had to switch to Claritin, for example. Usually that's a sign that you need to move on beyond antihistamines, that your placebo response to antihistamines is worn off. And it just means you need something more than antihistamines for the treatment of your allergies. But in reality, in terms of patients who need to use an antihistamine on a daily basis, if it's actually working and it's the therapy for you, it won't, quote unquote, stop working.
Okay. Is there a way to prevent PFAS?
Is there a way to prevent allergies? That's the harder question.
We're working on it.
Yeah. In in theory, if you are more aggressive about treating your underlying allergic rhinitis with immunotherapy earlier on, and you develop tolerization to environmental allergens earlier in the disease course, there's a lot of talk about using immunotherapy earlier in childhood to stop from allergic rhinitis progressing to asthma, for example. Um, so that, in theory, could prevent PFAS if you were more aggressive in your management of allergic rhinitis in childhood with immunotherapy. Is there
Okay.
data for that? No, but it would make sense.
Okay. Correlation between PFAS and eczema?
Great question. In as much as there is eczema is a risk factor for developing other allergies in the first place. So again, we talked about that atopic march. So eczema, then food allergy, then allergic rhinitis and asthma. Anything that puts you at risk for getting allergic rhinitis, therefore puts you at risk for PFAS down the road. So
Okay.
you do see a lot of patients of both, but not a direct risk.
Okay. Two more specific questions, and I'm going to just turn it back to you for some closing comments. Can PFAS increase the risk of exercise-induced anaphylaxis after outdoor endurance, like distance running?
So it's not so much that it increases the risk, but it's all part of the history taking when we're trying to sort out patients who have had anaphylaxis that seems to be exercise induced. But I don't think that I do see patients who have both PFAS and exercise induced anaphylaxis, again, celery being this common denominator between the two. But in terms of having PFAS, are you at higher risk for food dependent exercise induced anaphylaxis? No, it really does seem to be its own little beast.
Okay. Can PFAS be outgrown?
Not so much outgrown as better managed. If you take the right steps to get your hay fever and general allergies under better control, then your PFAS symptoms can get better too.
Okay, and I have one real last quick question. It was just kind of a really interesting one that came in. So someone who's got severe reactions to watermelon seed, but able to eat watermelon itself, is that PFAS or is that just a kind of a really odd allergy?
I would say it's a true allergy to the proteins in watermelon seeds and is different because, again, that's probably explaining why. I mean, nobody really wants to eat watermelon seeds anyway. They're not very yummy.
Right.
But yeah, I would say that it's similar to any sort of nut allergy. That's the core of a lot of fruit, right?
Yeah.
And that's probably where that all sort of comes into play for that particular patient.
Yeah, you know what? It feels like we all need to go back to science class and learn a lot about protein and protein structures and how they're influenced, because it's quite interesting. The science is complicated, and we really do appreciate all the work you do in this area to help us better understand it, ultimately to manage our conditions. Any final comments that you'd like to leave the audience with? Just any key messages that you'd like to wrap up with?
Yeah, I think it's important to recognize that an allergist can really be very helpful in this circumstance, and it certainly can provide a lot of reassurance, and hopefully, in the setting of where all you've had is itching of the mouth and throat, and really no other symptoms, it's probably worth seeing one of us to try to just reassure you that this is not something you need to carry an EpiPen for. And just having that detailed evaluation by a specialist can probably really improve your quality of life. So don't be afraid to ask your family doctor for a referral. Some of us may have long wait lists, but for many of us, it's worth the wait. So
Awesome. I really thank you for your time, Dr. Ellis. We appreciate the expertise, and I know our audience has learned a lot today. So thank you.
great. Thanks for
And
having me.
you're very welcome. I'm just going to finish up with just a few closing comments. I just want to remind everyone that you'll get a short survey and GoToWebinar immediately after this webinar that'll pop up on your screen. And you'll receive the survey in an email as well in the next hour. Please take a moment to complete it, because your feedback is really useful to us in improving our webinars, as well as better understanding what additional questions or comments you might have. Next month, we have a webinar, Know It, Treat It, Taking Control of Anaphylaxis with Dr. Wade Watson. We'll break down the signs and symptoms of anaphylaxis, clarify when and why to use epinephrine instead of antihistamines like Benadryl, and give you the tools to act quickly and confidently. You will also be presented with different scenarios so you can test your knowledge. It's back to school time. Let's be prepared and be confident for the upcoming school season. You can look at our resources and tools that are available at foodallergycanada.ca/back to school. You're going to find some checklists, some forms, some information sheet, and more. And plus, you can share our food allergy hacks that feature short tips on navigating the school year. And lastly, as many of you are aware in our audience, Food Allergy Canada is a not-for-profit charity. We're completely reliant on donations for the support of the work we do. If you can consider a donation to our organization, it would be greatly appreciated. You can visit foodallergycanada.ca/donate to learn more about the impact your donations can make. And we would like to thank our sponsors for our ongoing webinar series, the Schroeder Foundation, the Peanut Bureau of Canada, and EpiPen, and individuals like you. So thank you for your participation today. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share this with others who you think may benefit from this content. This now concludes our webinar.